On to the final video of this video series, dopamine diseases and disorders. Firstly, it's important to recognize dopamine's toxicity. As previously mentioned, patients with ischemic heart disease should be careful when dopamine is administered. Patients with pheochromocytoma and uncorrected ventricular fibrillation are also at risk. The effects can vary from vomiting to nausea to hypotension or urinary retention. And there's a lot more effects that can come from that. There can also be possible allergic reactions if dopamine is inhaled, ingested, or touched. Overdose can result in an increased blood pressure, an extravasation of a large amount of dopamine into surrounding tissue can occur, disrupting blood flow and causing tissue damage, leading to ischemic necrosis. Ischemic necrosis may result in death and shedding of tissue known as slow, and in rare cases, the damaged tissue can actually progress to gangrene. Dopamine administered through halothane or cyclopropane anesthesia can lead to ventricular arrhythmias, which is irregular heart beating, and hypertension, which is high blood pressure. Halogenated hydrocarbon anesthetics increase cardiac irritability, making caution necessary when using dopamine in such cases. Propranolol could reverse dopamine-induced ventricular arrhythmias, however. Now that we've covered the toxicity of dopamine, let's discuss its related disorders and diseases. Now, dopamine can either play two roles, being either the maker / mechanism of the disease or the therapy. Now, there are too many to list right now, but I've put them all on the screen for you to read. The standard treatment for most of these disorders or diseases it involves using dopamine agonists, which are drugs that try to mimic dopamine's physiological and neurological effects. For example, apomorphine, bromocriptine, and ridogotine. Or they can involve antagonists, which inhibit the dopamine activity by suppressing the release or absorption of dopamine. Now, first we're going to talk about some conditions that are the result of reduced dopamine activity. The first being PKU, or phenylketonuria. The lack of phenylalanine hydroxylase, which is the initial reactant for dopamine synthesis, leads to PKU. The deficiency in phenylalanine hydroxylase results in a surplus of phenylalanine. The surplus of phenylalanine then, in turn, turns into phenylketones, which are excreted in urine. PKU is an autosomal recessive disorder, which means it's inherited. That's what autosomal means. And recessive meaning you need to have two recessive genes in order to express the disorder. PKU can lead to severe mental retardation and epilepsy. Because phenylalanine hydroxylase is key in the synthesis of tyrosine, which is a precursor to tyrosine is a precursor to dopa, which is a precursor to dopamine, which is a precursor to melanin. Because of that, typically if people don't have phenylalanine, they're unable to get to that stage of melanin, and they often have blonde hair, blue eyes, and they lack pigment in their irises and skin. The only cure currently is a phenylalanine-free diet. As we've talked about, phenylalanine is only brought into the system through dietary consumption. The next disorder is dopamine responsive dystonia, or DRD. So, DRD is a genetic deficiency of both phenylalanine hydroxylase and tyrosine hydroxylase, and DRD only affects children. Its effects are very interesting. In the afternoon, and only in the afternoon, after dopamine stores are depleted, dystonia and involuntary movements will occur, similar to cerebral palsy. And this only occurs in the nighttime, but throughout the night, as children regain their dopamine stores, they will gain full muscle control again. And this cycle continues on day and night. This is easily curable with even small doses of L-Dopa. As L-Dopa is a precursor to dopamine, it will insert itself into the synthesis and bypass enzyme deficiencies, quickly allowing for nigrostriatal neuron synthesis. This reverses the symptoms quickly and easily. Next up, we can look at Parkinson's disease, which is very well documented. Parkinson's is the progressive degeneration of dopaminergic neurons in the substrata nigra. Neurologists currently attempt to do three things when trying to cure this. So, number one, they administer great amounts of dopamine precursors, such as L-DOPA, to try and improve the synthesis of dopamine. They also try and inhibit the metabolism of dopamine precursors, such as L-DOPA, as well as dopamine itself, and provide receptor agonists that can provide the same receptor effects. Now, when administering L-DOPA, it corrects the dopamine deficiency. However, research suggests that there's also a cholinergic deficit that's seen in Parkinson's disease patients that is not being targeted by just the L-DOPA administering. So progressively, the presynaptic neurons degenerate beyond the ability to convert DOPA to dopamine and store or release dopamine at all. So to treat this, dopamine agonists such as pramipexole, ropinirole, and apomorphine stimulate the receptors in a very similar manner to alleviate the symptoms. Carbidopa and entacapone inactivate enzymes that would metabolize L-DOPA, which is a precursor to dopamine, to enhance dopamine activity. Both carbidopa and entacapone work outside the central nervous system because of restrictions crossing the blood-brain barrier. The treatment reduces nausea, vomiting, cardiac arrhythmias, and hypotension, which is low blood pressure. Commercial preparation of treatments often combine both the enzyme inhibitors of carbidopa and entacapone and the doses of L-DOPA. These treatments almost entirely eliminate the side effects of nausea and vomiting. Another way to treat the deficiency is by inhibiting enzymes that metabolize dopamine itself, for example, MAO. Selagelline inhibits MAO-B, one of the major forms of MAO. By penetrating the blood-brain barrier and inhibiting MAO-B, it preserves dopamine from reuptake and increases the dopamine activity. It also produces amphetamine-like symptoms to sort of offset the Parkinson's disease symptoms that occur from fatigue and depression. So the symptoms of Parkinson's itself are resting tremor, bradykinesia, shuffling gait, and postural instability, as well as many other. Despite selagelline only inhibiting MAO-B, it never places patients at risk of hypertensive crisis, which is high blood pressure, which certain antipsychotics can do. Another disorder that can occur is medication-induced Parkinsonism. So patients who are currently being prescribed antipsychotic agents can sometimes develop Parkinson's disease symptoms as a result of the blocking of D2 receptors. L-DOPA administration would not be the most ideal solution in this scenario, given that this doesn't correct the symptoms or affect the blocked D2 receptors. Additionally, excess dopamine will stimulate the frontal cortex and limbic system dopamine receptors, which can exacerbate or cause a psychotic reaction. The best solution here is to, number one, diagnose the medical-induced Parkinsonism, two, to find alternative, more specific diagnosis that can match the patient's symptoms, and number three, postpone the antipsychotics and medication if possible. Now, onto the conditions due to excessive dopamine activity. So excessive dopamine activity is often as a result of administered L-DOPA, as well as illicit drugs such as cocaine and amphetamine that can provoke dopamine release in the receptors and block its reuptake. Psychiatric medication such as Wellbutrin inhibit dopamine reuptake, and excessive dopamine activities result in usually fairly common symptoms throughout all excessive dopamine activity, which is visual hallucinations and thought disorders that can reach almost psychotic proportions. Parkinson's disease patients who are administered L-DOPA will often have hallucinations and delusions as a result, despite the fact that they have the deficiency. It can also cause hyperkinetic movement disorders, such as tremor, tics, dystonia, and chorea. Pleasure and even euphoria can be induced by the increase in dopamine activity, and dopamine and its agonists can inhibit prolactin release. Dopamine receptor blockades can enhance prolactin release in serum concentration, however. Now, specifically looking at schizophrenia, we can see that it's caused by an increase in dopaminergic activity, and the genetic and environmental influences can impact how the dopamine functions. So the common symptoms are delusions, disorganized speech, hallucinations, disorganized behavior, and something called the flat effect. The treatment for schizophrenia attempts to decrease the dopamine levels due to the high amounts. Typical antipsychotics will often block the D2 receptor in specific. High potency options include haloperidol, trifluoperazine, and fluphenazine. Sorry for my possibly incorrect pronunciation. And low potency treatment can include chloropromazine and thioridazine. And that is it for this video. Thank you for watching, and thank you for listening to my whole video series in all. This took a lot of research to make, and I hope you enjoyed it. After finishing all 4 videos, you now should have the ability to access the battle feature at the top left of the screen. Please go have fun and compare your scores with all of the test runs and bots that I did to make sure that everything was working, since no one has technically played my game yet. So yeah, have fun, and sorry for making